This news is funded by viewers like you. Please support our work at democracynow.org/give. This is Democracy Now!, democracynow.org, the War and Peace Report. I'm Amy Goodman. Luigi Mangione, the suspect in the shooting death of UnitedHealthcare CEO Brian Thompson, appeared in a federal court here in New York Thursday after being extradited from Pennsylvania, where he was arrested. Prior to the court appearance, Mangione was seen in Lower Manhattan being escorted from a helicopter by the FBI, by the New York Police Department, and New York Mayor Eric Adams. He's been charged with first-degree murder, second-degree murder as an act of terrorism for fatally shooting Thompson on the morning of December 4th as the CEO was walking to UnitedHealth's annual investor conference. A newly filed federal complaint has revealed new details about a notebook Mangione had at the time of his arrest. According to authorities, it, quote, contains several handwritten pages that express hostility toward the health insurance industry and wealthy executives in particular. In a separate manifesto, Luigi Mangione wrote, quote, frankly, these parasites simply had it coming. A reminder, the U.S. has the #1 most expensive healthcare system in the world, yet we rank roughly 42 in life expectancy, he wrote. According to investigators, Mangione had written the words deny, defend, and depose on the bullet casings used in the assassination. The killing of the UnitedHealthcare CEO has brought renewed attention to the practices of the health insurance industry, and especially UnitedHealth Group, which made $22 billion in profits last year. We're joined now by two guests here in New York. Elisabeth Benjamin is with us. She is Vice President of Health Initiatives at the Community Service Society of New York. She's co-founder of Healthcare for All New York campaign. And Kevin Dwyer is with us. He's a cystic fibrosis patient who's written about his battle with UnitedHealthcare after he was denied life-saving medicine. You're a family of 7 kids?
Yes, correct.
4 of you have cystic fibrosis,
Correct,
Kevin?
yes.
So talk about what happened to you.
Well, in 2012, there was a new medication that came onto the market called Kalydeco. It was a game-changing medication for cystic fibrosis patients. It, instead of just treating the symptoms of the disease, which is previously that's all we had, it actually started to work at the root cause of cystic fibrosis and the defective gene. It was only for one specific mutation out of thousands of mutations for cystic fibrosis. I started to do research about the medication, about the specific gene, talked to my doctor. My sister then went and tried to get the medication.
And she get it?
And she got it, yes. I then went ahead with all the same information because we have the same gene, and I was denied by UnitedHealthcare.
She also had UnitedHealthcare.
She had UnitedHealthcare, yes.
UnitedHealthcare approved her prescription.
Correct. They denied her at first, and then she had to go through the appeal process. Mm-hmm. And at the appeal process, she got approved for the medication.
Well, you're looking very good now. I don't know what that means.
Yes.
But, so explain what happened, because you were not doing well after you were denied.
No, I was not. I was at a point in my health where it was starting to decline, and it was declining rapidly. At the time, I was probably about 30% lung capacity. You were put on a lung list to get a new lung? Yes, I was just about to be. We started having conversations about getting lung transplant, double lung transplant. So the thought of getting this medication that could stop my decline was everything to me. And it was devastating when I got the denial because my sister had just received the medication and I had used all the exact same information that she had used. To the same health insurance company, yes, United. And she was doing well? She was doing great. Her lung functions went up. She was clearing out the mucus in her lungs much easier as I was going the opposite direction. About to get on the lung transplant list. So what did it take for this to turn around for you? In the end, these days in America, you have to go to the doctor and a lawyer when you're sick? Absolutely, yes. It took a lot. I went to representatives, I went to doctors, I went to lawyers. I ended up finally going to health advocacy groups. the lawyer was helping, but in the end, the only thing that really got me the medication was it became a national story, and it was on the Today Show, and UnitedHealthcare just happened to change their tune and then gave me the medication.
Can you explain what happened? The Today Show called UnitedHealthcare and said, we're about to run this story?
Correct.
They had denied you right up until then.
Absolutely, yeah.
And when the Today Show called,
Yes.
they then called you and said it's going to be approved? If you don't go on the Today Show?
Absolutely, yes. There was a caveat there. There was, it was, you know, the question that was posed to me was, do you want this medication, or do you want your interview to run on the Today Show? So I said, well, of course I want the medication, but it can't be contingent on an interview, because they have my interview. They're going to do what they want to do. And so then there was negotiations, and then they finally came back and said, okay, you can have it, and you can go on the Today Show. And, you know, it's...
So this is what it takes, Elisabeth Benjamin. One of your steps was to go to Community Service Society. That's where you met Elisabeth Benjamin?
Right. Yes, yes. And honestly, when I went to her, after she got involved, the conversation started to change a little bit, but it still wasn't, they still weren't going to approve the medication, but at least she was able to get to some people that were able to maybe change the way they were looking at my case.
And Elisabeth, you too are a lawyer. You have several advanced degrees in public health, and you have a law degree. This is what it takes in America today to not get on the lung transplant list?
It shouldn't take this, but unfortunately it does. What we know from the research is, well, first of all, we don't know very much at all, because there's been a total abrogation by all government to actually require health insurance companies to report how many denials they issue. Some states do, some states don't. At the federal level, they're required to capture this data, but again, some states refuse to participate or have not participated, including, unfortunately, our own New York State, because it's sort of required in the Affordable Care Act to report the number of denials and the reason for the denials, but that's a law that's not basically being honored in the breach. So what we do know from the states that do participate in this one sort of subset of, get it, 350 million claims, so that's a pretty big subset, is that about 17% of all claims are denied. What we also know is the rates of denial are wildly random. In one state, it's 2%. In another state, it's 49%. So It's completely random where you live and what's going on in terms of the regulation of insurance carriers. And the other last sad thing from that same data set that we know is that less than 0.1% so 0.1 of 1% of people appeal. So the first thing I would always say to a patient is appeal, 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 because eventually you will prevail, although poor Kevin had the hardest appeal I've ever seen.
But eventually you won't necessarily win, right?
You won't necessarily.
But explain what it means to appeal. What do you do first?
So first of all, the first thing you should do if you get a claims denial is call your carrier and make sure that your provider submitted the right code.
And when you say provider, you mean your doctor?
Yes, your doctor. But it could be your hospital, it could be a doctor, it could be, the pharmacist. I mean, so that's why we say provider. It's sort of a euphemism for all these characters in your healthcare ecosystem. So the first thing you should do is call the insurance company and understand why they're denying the claim. And then circle back with your provider to make sure the right codes. If they say it's a coding issue or they didn't do a prior approval step or something like that, figure out what the problem is. If you're getting denied based on a thing called medical necessity, then you have a real chance in the appeal process to win. People on their own in New York State, thanks to Kevin and a bunch of us, we now know if people go to the state's external review process, on their own, they win about 45% of the time. So already you have...
What is the state's external review process?
Sure.
Who do you call?
So after you exhaust, go through all the appeals at your insurance carrier. If you have a medical necessity denial or an experimental investigation treatment denial, so if you have a denial that's not based on whether it's actually something that's covered by your insurance. So some people might ask your insurance company to pay for vitamins, and vitamins aren't covered, for example, in that plan. So then you have no real basis for your appeal. You just have to do whatever the carrier does. But most people who are denied really are denied based on medical necessity. Then you have the right to go through the state's, first the internal plan appeal process, which has very strict time limits. So make sure you understand those time limits. And then if you lose there, in almost every plan in America now, you have the right to go to an external appeal agent. And that agent in our state, it's a contractor or three contractors for the state of New York. Those people have independent doctors that look at the healthcare plan's decision. If you do that, you have a 50-50 chance of winning. If you come to us, you have an 87% chance of winning. So having an expert really pushes you along the sort of external appeal win chance.
And what is peer-to-peer? This not only affects patients like Kevin. You have doctors spending much of their time who wanted just to help patients negotiating prior approval, negotiating denials. The doctor then has to talk to an external doctor and say, this is why we think that he shouldn't need a new lung.
It's rarely a conversation. What the doctors have to do is even worse. They have to write like little dossiers in support. So there's no conversation. So it would that it was that easy. Sometimes the doctors get to talk to a nurse at United, but rarely it's to another doctor. Often it's nurses. Sometimes it's AI. We understand now more and more.
Artificial intelligence
is making some of these initial denials, is what we're being told. Although there's some states are trying to make that illegal. It's very bad because the way we regulate insurance is we don't. We basically let willy-nilly state do regulation. They do their best, but if we had a real understanding and real transparency about these denials and the nature of these denials, I think we would all know a lot more and maybe improve the system for everybody.
Do people answer the phone if you call up with a denial?
Eventually. I mean, wait times are not unheard of with any customer servicing.
And this is when you're getting sicker and sicker. Yes. So you're fighting the insurance company and fighting cancer.
Yeah. And there's a thing called in that case, there's a proven phenomena called financial toxicity. And so as you're dealing with medical debt or as you're dealing with an insurance claim, it actually exacerbates your physical condition. This has now been documented. And so for cancer survivors, there's a very important study in the Journal of American Medical Association. They're saying cancer survivors, as a result of the compounding financial toxicity, lose about 1 year of life and many more days in morbidity. So it's quite upsetting. And this is only happening in the United States, by the way. We don't have this financial toxicity issue in any of the other OECD countries. So it's a uniquely American phenomena.
And you're one of the founders of New York Healthcare for All.
Yes.
That goes to the issue of Medicare for All, of universal health care. And that's the phenomenon that is what we experience, they're not experiencing in those countries because they have basic health care.
Yes.
So talk about what that would mean. And the other issue you raised is the issue of medical debt, something else we just have here in this country.
Right, because we have this whole free market system for healthcare, which is, it's a free market health system. So you have the carriers who have their financial interests, insurance plans, and then you have the providers and hospitals who have all their financial interests. Those entities and the pharmacy, Big Pharma has its own financial interests. All of those entities are in sort of this nuclear arms race. Everybody has an incentive to charge more, right? Health plan makes more money because they just charge all of us more in premiums. So we all thought that the health plans would negotiate better hospital prices with the hospitals. But we see in a place like New York, the health plans are required basically to have all the hospitals, all the fancy hospitals in their networks. So there's no price controls happening. There's no real economics 101, the microeconomics we all might have learned in college or graduate school or whatever. It doesn't work in healthcare because it's an urgent, visceral, you have to have it. No one has bargaining power in this system. And so all the big financial interests just have an interest in making more money. So I think what happens in other countries is, for example, even in Switzerland, which has private health insurance, the government sets the reimbursement rates for the providers, for the drugs. And so the insurance companies are administering, private insurance is administering, but they're not administering the reimbursement rates. New York State used to set hospital reimbursement rates, and we got rid of that in favor of in favor of a free market system, and what's happened, our healthcare prices have gone up, and now we have the second most expensive healthcare in the country.
And you're one of the leaders on tackling medical debt. What is happening in the country around that state by state?
Well, what's amazing is the people are really fighting back. So here in New York State, we did an inventory of all the hospital lawsuits against patients, showed that about 13,000 patients were being sued by hospitals every year. We then went on this campaign.
So the sickest patients are being sued by hospitals saying, you've got to give us money.
Right.
Even though often they have a large charity disbursement that the patients didn't know about.
Right.
That if there's a person who can't afford, they get the money from the state.
Especially in a place like New York, where every one of our hospitals is a nonprofit charity. So I work for a charity. We never sue our patients. I mean, our clients. So I'm not sure why hospitals think that a nonprofit charitable entity thinks it's okay to sue their patients. Whole other story. But we just, from the people fighting, which is what is really starting to happen throughout the country, like what we did in New York is really spreading like wildfire, even in places like North Carolina that aren't known for their progressive policies necessarily. We started fighting back. We changed the statute of limitations. Hospitals now only have, and medical providers only have 3 years instead of 6 years to sue people. They used to be able to charge 9% interest. Now it's 2%. We no longer allow them to be able to report medical debt to the credit reporting agencies, so the debt collectors can't like hound you and terrify you into it, especially since we know from if you have medical debt, you're more likely to be a better credit risk than a bad one. So why would it ever be on your credit report? It just crazy. No longer can they get this, they used to take liens on people's homes, primary residences. They used to be able to take garnish wages of working people. Gone. No longer allowed to do that. And then finally, we made a total ban on suing anybody below 400% of the federal poverty level, which really saves.
How many states have this, though? This is New York.
This is New York. But we're seeing other states do that. Maryland has something very similar. The unions, in partnership with the people, have done a great job in their campaign in Maryland. We see some movement in Maine, Massachusetts, Illinois. Colorado's done a lot of work around this area, too. So
what would Medicare for All look like? How would that change the landscape for people, the health of the nation?
Well, first of all, right now we spend more, around 16% of our GDP on healthcare. If we had a Medicare for All system, that would probably, even in the most expensive other industrialized country, it's around 10, 12%. So we would save billions, trillions probably, if we had Medicare for All. And so all of that could go into paychecks and making people's lives better, right? So we would have the money instead of giving it to these big industries. The second thing that would happen is that we wouldn't have people with a thing called deductibles and co-insurance. So in a way to deter utilization, the industry tries to vilify patients like we're just desperate to overconsume healthcare. That's actually not true. We have the lowest average length of stay in hospitals compared to any OECD country. So it's not about patient utilization. It's truly about the prices. And there was a famous Princeton economist, U.E. Reinhardt, who died. He said, it's the price is stupid. And it really, and that was a famous article, but it's still true these 20 years later. So it's very sad. If we had Medicare for All, we wouldn't be paying as much, and we would probably have much better health outcomes, because people, it wouldn't be irrational if Kevin gets his treatment or not. People would, we'd have a higher life expectancy, we'd have better health outcomes, we could monitor quality, enforce quality around the system. It would just be so much easier for patients. Patients wouldn't have medical debt. Providers wouldn't be spending time with the insurance company and on paperwork. They could be actually providing health care to us.
And the discussion is going in the other direction with the new administration, not just not Medicare for All, but privatizing Medicare and Social Security.
Right, which means that there's more cost sharing for patients, right? Deductibles, co-insurance, higher co-pays. And it'd be one thing if we had all of those things were structured in a way to incentivize people getting care. So, for example, what that means is if someone has diabetes and needs insulin, we all want them to have insulin. If they don't take their insulin, they shouldn't be rationing their insulin. If they don't take their insulin, they're going to lose a foot. That's super expensive for all of us, right? But instead, we put copays and deductibles on insulin. So what's amazing is really smart states like New York last year under Governor Hochul and the Superintendent of Financial Services said, we're going to have zero copays for insulin. Like, why? Why would you ever charge people for insulin, period? That should just, the insurance company should want to have that person using their insulin. We should be doing that for a range of medications to really be improving healthcare for people instead of for profit.
Democracy Now! Is funded by viewers like you. Please give today at democracynow.org/give.